Okay, I'd like to thank you, the invited office in all the sympathetic guys from Portugal. Thank you. I'd like to invite you all to join us in the Brazilian Symposium of Injection Therapy. You are invited to meet us in the next September. We'll give you some printouts. You can feel that you will become a member of our society. If you do that, it's completely free, and you will receive discounts, and you'll have access to the logged in section of our site. So there we have a lot of material and scientific papers and things like that. I have no conflict of interest for this presentation. I'd like to ask you some questions to you. Which of you perform physical supplementation? Please raise your arm. Perfect. Almost everybody. Who anesthetizes the subcutaneous before doing the injection? Okay. And who injects anesthetic inside the joint to prevent pain? It normally occurs when you do some these procedures. Some of you, okay. So everything that should be put inside the joint is safe. This is the question that we try to answer in this presentation. I would like to show you a case about 10 years ago. It's 47 years old, 2 months after arthroscopy. This patient was referred to our hospital. We are our university hospital, and the guy that our colleague refers to us because they have a different evolution. This patient has no fever. He has a loss of movement. He has some warm shoulder, some kinds of inflammation. We did an aspiration and a culture, but both are negative. This patient evolves, and this is interesting in his history. And after the surgery, during 2 days, they remain with a catheter, a drain, epidural catheter, and the surgeon puts some kind of anesthetics. The patient didn't know exactly what he receives. And every 6 hours, he receives the substances inside his joints, and he is completely free of pain. He was very satisfied with the evolution of the surgery. But 15 days after, the pain returns. But what happened? It's a kind of low-grade infection with negative culture, maybe. Did the infiltration solution cause some kind of chondrocyte injury? Or does the solution use to decrease the oxygen solubility? All possible. And 6 months after, the patient loses completely movement, and the image shows that he has intense chondrolysis. We remain almost 2 years without a response for the event, but in the AO meeting in 2010 in New Orleans, we saw a presentation showing about the surgery arthroscopy using pain pumps. I called the colleague that refers to us, and they said to us that it was in the United States about 4 or 5 years ago, see this kind of treatment, and did it with a lot of patients in Brazil. They use bupivacaine and 2.5% for 38 hours, and this allows early movement. But it's important to remember that it's a lot off-label treatment. In 2007, there are several reports in the literature on the chondrolysis after arthroscopy and analgesia with intra-articular infusion pump. And Hansen suggests that the chondrolysis could be caused by the bupivacaine. In the next year, Drago did a study using young chondrocytes culture, and they discovered 2.25 to 0.5 bupivacaine infusion pump could cause minimal chondrocyte necrosis, but if you associate these substances with adrenaline that has a low pH that's less than or equal to 4, this necrosis increases. In interesting paper in AOS now in September 2009, Bushfield and colleagues did review what are happening in US. They stated that the use of pain pump is an off-label treatment. They have approximately 2 documented cases of chondrolysis using pump, and over 300 shoulder surgeons were being sued because they attributed to poor outcome to the post-traumatic glenohumeral chondrolysis caused by the bupivacaine. So, should we use pain pump with bupivacaine as an intra-articular analgesia after arthroscopy? And the answer of this question is no. Is the infiltration of intra-articular corticosteroid associated with lidocaine safe? In 2009, an important paper comparing saline solution and lidocaine associated with methylprednisolone shows that after 1 hour, about 97% of the chondrocytes die. So lidocaine is chondrotoxic, and in combination with methylprednisolone, after 1 hour, almost all the chondrocytes die. So think about that when you use lidocaine again inside the joint. So, is infiltration of intra-articular corticosteroid associated with lidocaine safe? No, it's not safe. Do our anesthetic has the same chondrotoxicity as lidocaine? Another paper from Dragoo in 2012. They use a human chondrocytes culture, saline solution, 2.9 mortality, and 1% of lidocaine, almost 3 times the mortality of the saline solution. The mortality with the bupivacaine 2.25 and bupivacaine 2.5 was equal to the control. Do the young chondrocytes have the same sensibility as the old chondrocytes? Anita Brill did this important paper and it took cytotoxicity of bupivacaine, and lidocaine, and they used human chondrocytes. And they stated that probably the most important thing that all these anesthetics are chondrotoxic, but it is time dependent, concentration dependent, and drug dependent manner. The chondrotoxicity and the analgesic potentials do not correlate. The cellular death rates were higher in the arthritis compared with intact cartilage after local anesthetic treatment. So, do all anesthetics have the same chondrotoxicity as lidocaine? No. Bupivacaine at 0.25 and bupivacaine 2.5 seems to be safe and less chondrotoxic. But take care if you are using these substances in old and orthoarthritic joints. Are there alternatives to intra-articular analgesia? It seems there is, and probably they are the opioids. ISIAT in 2014 tested the chondrotoxicity of the morphine and the morphine 6-glutamidine, and they stated that this substance could be an alternative to the intra-articular injection to the anesthetic because they are less chondrotoxic than the bupivacaine and the bupivacaine. Are there substances that can decrease the chondrotoxicity? I say, you must put something inside the joint, but eventually you need to do that. But it's something that you could put together. So they tested hyaluronic acid to decrease this chondrotoxicity. So there is the administration of hyaluronic acid with lidocaine in a high concentration, 2%, and bupivacaine in a high concentration, 0.5%. The hyaluronic acid shows that counterproductive effects to the bupivacaine, but the hyaluronic acid was not able to decrease the chondrotoxicity from the lidocaine. Does the hyaluronic acid decrease the apoptotic effect of bupivacaine? In another paper, this with the rat chondrocytes, and they tested a lot of concentrations of bupivacaine. So hyaluronic acid gives a protection in the highest 24 hours, but after 24 hours, if you maintain this solution with the chondrocytes, they recover the capacity to be chondrocyte. Another substance is the vitamin C. This was a paper published in our Revista Brasileira de Anestesiologia. It's a Brazilian paper. And they tested the bupivacaine 2.5 and bupivacaine 0.75 and lidocaine to 1% in a lot of doses. The vitamin C was observed to effectively protect the chondrocytes against the toxic insult of local anesthetics, bupivacaine, and lidocaine. So could be promised in the future some kind of association between these two substances. So in conclusion, hyaluronic acid and vitamin C decreases the chondrotoxicity of anesthetic toxicity, but prolonged use of intra-articular remains contraindicated as the effect diminishes after 24 hours. Is peri-articular use of local anesthetic safe? Can we anesthetize even the joint capsule without involving the joint? Using a pain pump in the subacromial space was safe. So if you are not inside the joint, there is no problem. In another paper, in the wrist, after arthroscopy of the wrist, there is no kind of chondrotoxicity. And they were compared the bupivacaine and saline solution. There's any kind of chondrotoxicity in the preservative or corticosteroid injections. There is some deleterious effect on cartilage, and even arthropathy have been reported after intra-articular corticosteroid injections. And the conclusion of this important paper is that corticosteroid per se did not cause significant death of the tested condition, but the preservative mesoconium chloride causes death in chondrocytes and synovial in both bovine and human cells. So Dragoo resolved to test decadron, depomedrol, celestone, and kenalog. All of them have some kind of chondrotoxicity, but only celestone that use benzalkonium chloride as a chondrotoxic is chondrotoxic and should be used with caution. So the take-home message: peri-articular use of low concentration of anesthetic is safe, mainly bupivacaine 0.25. Hyaluronic acid decreases the chondrotoxicity of low concentration of the anesthetics. If you want to use intra-articular analgesia, morphine is less chondrotoxic than the anesthetic, so prefer to use morphine. Avoid the use of intra-articular lidocaine. Probably, eventually, this is the main take-home message for you. If you need to put anesthetic inside the joints, prefer to use bupivacaine or hopivacaine in low concentrations. Intra-articular corticosteroids in arthrose. Do not use injections with benzalkonium chloride. And I once more invited you to join us in the meeting of our society, is Brazos, the Society of Arthritis, Osteoporosis and Sarcopenia. We think that these three pathologies are three faces of the same disease. We held you and we are waiting you in Rio de Janeiro, 24, 26 of September of next year. Please save the date. Thank you.
Thank you, Marco, for this interesting and informative presentation. And put your presentation to discussion. Please.
Can I ask about your vitamin C? Was it given intra-articularly?
Yes, in that paper, they were tested in chondrocytes culture. We don't have any kind of paper or study in humans.
I enjoyed the presentation very much. Just a comment, perhaps. One of the potential criticism of the body of work might be that chondrocytes lose their phenotype rapidly when they're in culture, and perhaps this type of testing paradigm is artificial. But I would caution that point of view because this is how quinolones were first identified as being so specifically chondrocyte toxic based on simple monolayer culture.
Yes, and all of these papers try to compare with saline solution because they try to focus only in the percentage of the increase when he compares with the saline solution.
What about the trauma, intra-articular injection of trauma and post-operative pain control?
To inject what? Could you repeat?
Tramadol.
Tramadol. There are some papers in the literature